Episode 2, Chapter 33, going to talk about the hiatal hernia. A hiatal hernia happens when the lower part of the esophagus and the upper part of the stomach slip up through the diaphragm. Here's your diaphragm like this. And if you can imagine it, you're going to have your stomach and your esophagus slip up through and kind of get stuck up in your chest area here. When that happens, you can imagine the signs and symptoms by just having something that's in your chest that's not supposed to be there. So that person's going to have difficulty swallowing, they're going to have a feeling of fullness, and they're going to have gastric esophageal reflux. So how are we going to deal with that? First of all, the doctors are going to diagnose that through x-ray and probably a barium swallow, which is, I hope you guys remember, an upper GI series. Then what we as nurses, and this is really where a lot of the test questions are going to come from, we as nurses have to remember how to treat that non-medically. So of course the doctors are going to give antacids. That's going to be fine from the doctor's standpoint, and then the doctors are going to probably, if the hernia is small enough, they're not going to have to do anything. But if it's big, then they'll do a surgical treatment called a fundoscopy. Wait a minute, let me just say the right word here. Sorry, fundoplication. That's the right word, fundoplication. And that's where they will actually take a bit of the stomach and they'll wrap it around the esophagus so it stays below the diaphragm. So basically, instead of being able to slip up through, they're going to take it and like put a ring around the top part so that it won't slip up through the diaphragm anymore. So that process is called fundoplication. But as nurses, what we want to focus on with somebody with a hiatal hernia are things, interventions that we can do that until the surgery takes place will help our patient be comfortable. So let's think about that. If they have feeling of fullness because the esophagus and the upper part of the stomach is in their throat, one of the things that we can do is have them chew their food thoroughly, take smaller bites, and to eat smaller meals. Instead of one big meal or 3 big meals a day, they want to eat smaller meals throughout the day and chew their food thoroughly. The other thing that we want to teach is that they don't need to eat snacks before they go to bed. They need to stay upright, meaning they shouldn't recline for at least 1 hour after they eat. And then the other thing is that their bed, the head of the bed, should be raised 6 to 8 inches. Okay, foods to avoid would be foods that cause irritation, such as spicy foods, alcohol, caffeine, and smoking. Those are the 4 irritants that are involved with hiatal hernia. So, to recap, hiatal hernia is where the esophagus and the upper part of the stomach come up through the diaphragm and get stuck. And there can be a sliding hiatal hernia where it'll come up and then it'll go back down, it'll come up and go back down. That's the hiatal hernia. Signs and symptoms of that would be fullness, vomiting, difficulty swallowing, and GERD. Treatments from the nursing intervention standpoint is going to be small, frequent meals, chewing your food all the way, giving them the antacids on a scheduled basis, and elevating the bed 6 to 12 inches, making sure that the patient doesn't recline for at least an hour after they eat. Excuse me. All right. Then we're going to talk about GERD, gastric esophageal reflux disease. And what happens with GERD is that the stomach acids actually come up into the esophagus and cause burning. So one of the things that we want to look for, signs and symptoms, are going to be heartburn, regurgitation, dysphagia, meaning difficulty swallowing, and bleeding. And the bleeding is going to come from the tears of our esophagus is highly vasculature. It has a lot of vascular. It's highly vascular, and it has just a lot of small vessels in there. So if we cough too much, if we vomit too much, it can cause those vessels to break and then to bleed. So that's where the bleeding comes from with GERD. So one of the things that we can expect, of course, is that the doctor is probably going to give us an antacid of some kind, usually a proton pump inhibitor. That's your Nexium, your Pepcid, Tagamet. Those are proton pump inhibitors. Protonix is something that you see in the hospital a lot of. Okay, how are they going to diagnose GERD? Usually they're going to do two main things. They'll either do an upper GI, which is a barium swallow, or they'll do a EGD, esophageal gastroduodenoscopy, and they'll be able to see the esophagitis, or the inflammation of the esophagus that's caused by the GERD, or the acid reflux that happens in your esophagus. Now, that in and of itself isn't so bad if you can control it, but what happens is if GERD is left uncontrolled, then what will end up happening is that you can develop a condition in your throat called Barrett's esophagus. And what that is those are actually precancerous lesions that are caused by constant inflammation and constant irritation of the esophagus from the acid. So then the doctors will actually have to go in there and remove those precancerous cells, and when they do that, then good esophageal tissue will grow back, and you've removed that threat of cancer. So uncontrolled GERD can lead to Barrett's esophagus, which, if that's left uncontrolled, can lead to esophageal cancer. Okay, so lifestyle changes. That's how, one of the ways that we're going to treat GERD. We're going to have a low-fat, high-protein diet. We're going to suspect that the doctor is going to give proton pump inhibitors, like I said. And I'm just looking real quick, I'm sorry. And then one of the newer procedures that they're just trying now is where they go in with an endoscope and they try and tighten the sphincter, the esophageal sphincter, so that the acid can't shoot back. But that's in severe GERD. Mild GERD, Mylanta, more moderate to severe, they're going to do proton pump inhibitors, and then with severe to debilitating, they're going to try and do the closure or the stricturing of the esophageal sphincter, and hopefully they'll prevent that from developing into Barrett's esophagus, which is the precancerous esophagus, and then that'll prevent then from going into esophageal cancer. Okay. Next thing I want to talk to you about is a peptic ulcer disease. Peptic ulcer disease is